Post-concussion syndrome, also known as post-concussive syndrome or PCS, is a set of symptoms that may continue for weeks, months, or a year or more after a concussion, a mild form of traumatic brain injury. The rates of PCS vary, but most studies report that about 15% of individuals with a history of a single concussion develop persistent symptoms associated with the injury. A diagnosis may be made when symptoms resulting from concussion last for more than 3 months after the injury. Loss of consciousness is not required for a diagnosis of concussion or post-concussion syndrome. The condition is associated with a wide range of symptoms: physical, such as headache; cognitive, such as difficulty concentrating; and emotional and behavioral, such as irritability. Many of the symptoms associated with PCS are common and may be exacerbated by other disorders, so there is considerable risk of misdiagnosis. Headaches that occur after a concussion may feel like migraine headaches or tension-type headaches. Most headaches are tension-type headaches, which may be associated with a neck injury that occurred at the same time of the head injury. Though there is no treatment for PCS, symptoms can be treated. Medications and physical and behavioral therapy may be used, and individuals can be educated about symptoms and provided with the expectation of recovery. The majority of PCS cases resolve after a period of time. It is not known what causes PCS to occur and persist, or why some people who suffer a minor traumatic brain injury later develop PCS while others do not. The nature of the syndrome and the diagnosis itself have been the subject of intense debate since the 19th century. However, certain risk factors have been identified. For example, pre-existing medical or psychological conditions, expectations of disability, being female, and older age all increase the chances that someone will suffer PCS. Physiological and psychological factors present before, during, and after the injury are all thought to be involved in the development of PCS. Some experts believe post-concussion symptoms are caused by structural damage to the brain or disruption of neurotransmitter systems, resulting from the impact that caused the concussion. Others believe that post-concussion symptoms are related to common psychological factors. Most common symptoms like headache, dizziness, and sleep problems are similar to those often experienced by individuals diagnosed with depression, anxiety, or post-traumatic stress disorder. In many cases, both physiological effects of brain trauma and emotional reactions to these events play a role in the development of symptoms. Signs and symptoms. In the past, the term PCS was also used to refer to immediate physical symptoms or post-concussive symptoms following a minor TBI or concussion. The severity of these symptoms typically decreases rapidly. In addition, the nature of the symptoms may change over time. Acute symptoms are most commonly of a physical nature, while persisting symptoms tend to be predominantly psychological. Symptoms such as noise sensitivity, problems with concentration and memory, irritability, depression, and anxiety may be called late symptoms because they generally do not occur immediately after the injury, but rather in the days or weeks after the injury. Nausea and drowsiness commonly occur acutely following concussion. Headache and dizziness occur immediately after the injury, but also can be long-lasting. Physical. A common condition associated with PCS is headache. While most people have headaches of the same type they experienced before the injury, people diagnosed with PCS often report more frequent and longer-lasting headaches. Between 30% and 90% of people treated for PCS report having more frequent headaches, and between 8% and 32% still report them a year after the injury. Dizziness is another common symptom reported in about half of people people diagnosed with PCS and is still present in up to a quarter of them a year after the injury. Older people are at especially high risk for dizziness, which can contribute to subsequent injuries and higher rates of mortality due to falls. About 10% of people with PCS develop sensitivity to light or noise. About 5% experience a decreased sense of taste or smell, and about 14% report blurred vision. People may also have double vision or ringing in the ears, also called tinnitus. PCS may cause insomnia, fatigue, or other problems with sleep. Psychological and behavioral. Psychological conditions, which are present in about half of people with PCS, may include irritability, anxiety, depression, and a change in personality. Other emotional and behavioral symptoms include restlessness, aggression, and mood swings. Some common symptoms, such as apathy, insomnia, irritability, or lack of motivation, may result from other co-occurring conditions, such as depression. Higher mental functions. Common symptoms associated with the diagnosis of PCS are related to cognition, attention, and memory, especially short-term memory, which can also worsen other problems such as forgetting appointments or difficulties at work. In one study, 1 in 4 people diagnosed with PCS continued to report memory problems a year after the injury, but most experts agree that cognitive symptoms clear within 6 months to a year after injury in the vast majority of individuals. Causes. The question of the causes of PCS has been heavily debated for many years and remain controversial. It is not known to exactly what degree the symptoms are due to physiological changes or to other factors, such as pre-existing psychiatric disorders or factors related to secondary gain or disability compensation. The subjectivity of the complaints complicates assessment and makes it difficult to determine whether symptoms are being exaggerated or feigned. While the causes of symptoms occurring immediately after a concussion are likely to be physiological, it is less evident that persistent post-concussive symptoms have an entirely organic basis, and non-organic factors are likely to be involved in symptoms that last longer than 3 months. PCS may also be exacerbated by psychosocial factors, chronic pain, or an interaction of some or all of these. The majority of experts believe that PCS results from a mix of factors, including pre-existing psychological factors and those directly relating to the physical injury. Physiological conventional neuroimaging studies of the brain following a concussion are typically normal. However, studies have found some subtle physiological changes associated with PCS using more novel imaging modalities. Studies using positron emission tomography have linked PCS to a reduction in glucose use by the brain. Changes in cerebral blood flow have also been observed as long as 3 years after a concussion in studies using single photon emission computed tomography. At least one study with functional magnetic resonance imaging has shown differences in brain function during tasks involving memory after MTBI. Although they were not examining PCS specifically, additional studies have shown, using various MRI techniques that individuals with PCS have various abnormalities in the brain structure. Similar findings have recently been reported in soldiers with blast-induced MTBI PCS. Not all people with PCS have abnormalities on imaging, however, and abnormalities found in studies such as fMRI, PET, and SPECT could result from other comorbid conditions such as depression, chronic pain, or post-traumatic stress disorder. Proponents of the view that PCS has a physiological basis point to findings that children demonstrate deficits on standardized tests of cognitive function following a mild TBI. A few studies have shown that people with PCS score lower than controls on neuropsychological tests that measure attention, verbal learning, reasoning, and information processing, but issues related to effort and secondary gain cannot be ruled out as contributing to these differences. Recovery as measured by scores on cognitive tests frequently do not correlate with resolution of symptoms. Individuals diagnosed with PCS may still report subjective symptoms after the performance on tests of cognitive functioning have returned to normal. Another study found that although children with PCS had poorer scores on tests of cognitive functioning after the injury, they also had poorer behavioral adjustment before the injury than children with no persistent symptoms. These findings support the idea that PCS may result from a combination of factors such as brain dysfunction resulting from head injury and pre-existing psychological or social problems. Different symptoms may be predicted by different factors. For example, one study found that cognitive and physical symptoms were not predicted by the manner in which parents and family members coped with the injury and adjusted to its effects, but psychological and behavioral symptoms were. Psychological. It has been argued that psychological factors play an important role in the presence of post-concussion symptoms. The development of PCS may be due to a combination of factors such as adjustment to effects of the injury, pre-existing vulnerabilities, and brain dysfunction. Setbacks related to the injury, for example problems at work or with physical or social functioning, may act as stressors that interact with pre-existing factors such as personality and mental conditions to cause and perpetuate PCS. In one study, levels of daily stress were found to be correlated to PCS symptoms in both concussed subjects and controls, but in another, stress was not significantly related to symptoms. Iatrogenic effects may also occur when individuals are provided with misleading or incorrect information related to recovery of symptoms. This information may cause people to focus and dwell on the idea that the brains are permanently damaged. It appears that even the expectation of symptoms may contribute to the development of PCS by causing individuals with MTBI to focus on symptoms and, therefore, perceive them to be more intense, to attribute symptoms that occur for other reasons to the injury, and to underestimate the rate of symptoms before the injury. Diagnosis. The International Statistical Classification of Diseases and Related Health Problems and the American Psychiatric Association's Diagnostic and Statistical Manual of Mental Disorders have set out criteria for PCS and post-concussional disorder, respectively. The ICD-10 established a set of diagnostic criteria for PCS in 1992. In order to meet these criteria, a patient has had a head injury, usually sufficiently severe to result in loss of consciousness, and then develop at least 3 of the 8 symptoms marked with a check mark in the table at right under ICD-10 within 4 weeks. About 38% of people who suffer a head injury with symptoms of concussion and no radiological evidence of brain lesions meet these criteria. In addition to these symptoms, people that meet the ICD-10 criteria for PCS may fear that they will have permanent brain damage, which may worsen the original symptoms. Preoccupation with the injury may be accompanied by the assumption of a sick role and hypochondriasis. The criteria focus on subjective symptoms and mention that neuropsychological evidence of significant impairment is not present. With the focus on psychological factors, the ICD-10 criteria support the idea that the cause of PCS is functional. Like the ICD-10, The ICD-9-CM defines PCS in terms of subjective symptoms and discusses the greater frequency of PCS in people with histories of mental disorders or a financial incentive for a diagnosis. The DSM-IV lists criteria for diagnosis of PCD in people who have suffered a head trauma with persistent post-traumatic amnesia, loss of consciousness, or post-traumatic seizures. In addition, for a diagnosis of PCD, patients must have neuropsychological impairment as well as at least 3 of the symptoms marked with a check mark in the table at right under DSM-IV. These symptoms must be present for 3 months after the injury and must have been absent or less severe before the injury. In addition, the patient must experience social problems as a result, and must not meet criteria for another disorder that explains the symptoms better. Neuropsychological tests exist to measure deficits in cognitive functioning that can result from PCS. The Stroop color test and the 2-NAM-7 processing speed test can predict the development of cognitive problems from PCS. A test called the Rivermead Post-concussion Symptoms Questionnaire, a set of questions that measure the severity of 16 different post-concussion symptoms, can be self-administered or administered by an interviewer. Other tests that can predict the development of PCS include the Hopkins Verbal Learning A test and the Digit Span Forward Examination. The HVLA tests verbal learning and memory by presenting a series of words and assigning points based on the number recalled, and Digit Span measures attention efficiency by asking the examinee to repeat back digits spoken by the tester in the same order as they are presented. In addition, neuropsychological tests may be performed to detect malingering. Differential diagnosis. PCS, which shares symptoms with a variety of other conditions, is highly likely to be misdiagnosed in people with these conditions. Cognitive and affective symptoms that occur following a traumatic injury may be attributed to MTBI, but in fact be due to another factor such as post-traumatic stress disorder, which is easily misdiagnosed as PCS and vice versa. Affective disorders such as depression have some symptoms that can mimic those of PCS and lead to a wrongful diagnosis of the latter. These include problems with concentration, emotional lability, anxiety, and sleep problems. Depression, which is highly common in persistent PCS, can worsen other PCS symptoms, such as headaches and problems with concentration, memory, and sleep. PCS also shares symptoms with chronic fatigue syndrome, fibromyalgia, and exposure to certain toxins. Traumatic brain injury may cause damage to the hypothalamus of the pituitary gland, and deficiencies of pituitary hormones can cause similar symptoms to post-concussion syndrome. In these cases, symptoms can be treated by replacing any hormones that are deficient. Treatment. Management of post-concussion syndrome typically involves treatments addressing specific symptoms. For example, people can take pain relievers for headaches and medicine to relieve depression or insomnia. Rest is advised, but is only somewhat effective. Physical and behavioral therapy may also be prescribed for problems such as loss of balance and difficulties with attention, respectively. Medication. Though no pharmacological treatments exist for PCS, doctors may prescribe medications used for symptoms that also occur in other conditions. For example, antidepressants are used for the depression that frequently follows MTBI. Side effects of medications may affect people suffering the consequences of MTBI more severely than they do others, and thus it is recommended that medications be avoided if possible. There may be a benefit to avoiding narcotic medications. In addition, some pain medications prescribed for headaches can cause rebound headaches when they are discontinued. discontinued. Psychotherapy, psychological treatment, to which about 40% of PCS patients are referred for consultation, has been shown to reduce problems. Ongoing disabilities may be treated with therapy to improve function at work, or in social or other contexts. Therapy aims to aid in the gradual return to work and other pre-injury activities as symptoms permit. A protocol for PCS treatment has been designed based on the principles behind cognitive behavioral therapy, a psychotherapy aimed at influencing disturbed emotions by improving thoughts and behaviors. CBT may help prevent persistence of iatrogenic symptoms, those that occur because healthcare providers create the expectation that they will. A risk exists that the power of suggestion may worsen symptoms and cause long-term disabilities. Therefore, when counseling is indicated, the therapist must take a psychological origin of symptoms into account and not assume that all symptoms are a direct result of neurological damage. For the injury, in situations such as motor vehicle accidents or following a violent attack, the post-concussion syndrome may be accompanied by post-traumatic stress disorder, which is important to recognize and treat in its own right. People with PTSD, depression, and anxiety can be treated with medication and psychotherapy. Education about symptoms and the usual time course is a part of psychological therapy, and is most effective when provided soon after the injury, since stress exacerbates post-concussion symptoms, and vice versa. An important part of treatment is reassurance that PCS symptoms are normal, and education about how to deal with impairments. One study found that PCS patients who were coached to return to activities gradually told what symptoms to expect, and trained how to manage them had a reduction in symptoms compared to a control group of uninjured people. Early education has been found to reduce symptoms in children as well. Neurotherapy is an operant conditioning test where patients are given conditional audio-visual rewards after producing particular types of brainwave activity. Recent neurotherapy improvements in QEEG can identify the specific brainwave patterns that need to be corrected. Studies have shown that neurotherapy is effective in the treatment of post-concussion syndrome and other disorders with similar symptoms. Prognosis. The prognosis for PCS is generally considered positive, with total resolution of symptoms in many, but not all, cases. For 50% of people, post-concussion symptoms go away within a few days to several weeks after the original injury occurs. In others, symptoms may remain for 3 to 6 months, but evidence indicates that many cases are completely resolved within 6 months. The majority of symptoms are largely gone in about half of people with concussion 1 month after the injury, and about 2/3 of people with minor head trauma are nearly symptom-free within 3 months. Persistent or often severe headaches are the longest lingering symptom in most cases and the most likely symptom to never fully resolve. It is frequently stated in the literature and considered to be common knowledge that 15 to 30% of people with PCS have not recovered by a year after the injury, but this estimate is imprecise because it is based on studies of people admitted to a hospital, the methodologies of which have been criticized. In approximately 15% of people, symptoms may persist for years or be permanent. If symptoms are not resolved by 1 year, they are likely to be permanent, though improvements may occur after even 2 or 3 years, or may suddenly occur after a long time without much improvement. Older people and those who have previously suffered another head injury are likely to take longer to recover. The way in which children cope with the injury after it occurs may have more of an impact than factors that existed prior to the injury. Children's mechanisms for dealing with their injuries may have an effect on the duration of symptoms, and parents who do not deal effectively with anxiety about children's post-injury functioning may be less able to help the children recover. If another blow to the head occurs after a concussion but before its symptoms have gone away, there is a slight risk of developing the serious second impact syndrome. In CIS, the brain rapidly swells, greatly increasing intracranial pressure. People who have repeated mild head injuries over a prolonged period, such as boxers and gridiron football players, are at risk for chronic traumatic encephalopathy, a severe chronic disorder involving a decline in mental and physical abilities. Epidemiology. It is not known exactly how common PCS is. Estimates of the prevalence at 3 months post-injury are between 24 and 84%, a variation possibly caused by different populations or study methodologies. The estimated incidence of PPCS is around 10% of MTBI cases, since PCS by definition only exists in people who have suffered a head injury. Demographics and risk factors are similar to those for head injury. For example, young adults are at higher risk than others for receiving head injury, and, consequently, of developing PCS. The existence of PCS in children is controversial. It is possible that children's brains have enough plasticity that they are not affected by long-term consequences of concussion. On the other hand, children's brains may be more vulnerable to the injury, since they are still developing and have fewer skills that can compensate for deficits. Clinical research has found higher rates of post-concussion symptoms in children with TBI than in those with injuries to other parts of the body, and that the symptoms are more common in anxious children. Symptoms in children are similar to those in adults, but children exhibit fewer of them. Evidence from clinical studies found that high school-aged athletes had slower recoveries from concussion as measured by neuropsychological tests than college-aged ones and adults. PCS is rare in young children. Risk factors. A wide range of factors have been identified as being predictive of PCS, including low socioeconomic status, previous MTBI, a serious associated injury, headaches, an ongoing court case, and female gender. Being older than 40 and being female have also been identified as being predictive of a diagnosis of PCS, and women tend to report more severe symptoms. In addition, the development of PCS can be predicted by having a history of alcohol abuse, low cognitive abilities before the injury, a personality disorder, or a medical illness not related to the injury. PCS is also more prevalent in people with a history of psychiatric conditions such as clinical depression or anxiety before the injury. Mild brain injury-related factors that increase the risk for persisting post-concussion symptoms include an injury associated with acute headache, dizziness, or nausea, an acute Glasgow Coma score of 13 or 14, and suffering another head injury before recovering from the first. The risk for developing PCS also appears to be increased in people who have traumatic memories of the injury or expect to be disabled by the injury.